America Healthy Again Task Force. Before we start, Madam Clerk, please call the roll.
Senator Chambers Armstrong, Senator Douglas,
Present.
Senator Richardson, Senator Wheeler, Representative Callaway, Representative Duvall,
Here.
Representative Moore, Representative Proctor, Co-Chair Funky Fromeyer,
Present.
Co-Chair Lockett.
Here. We are working on an overflow room, so those of you that are standing will have a place to sit. So just keep that in mind, and we'll announce that once that is up and running with technology and KET as well. We are going to jump right into our agenda today. I do want to remind you that we do have a lot of our presenters today. They have all been told in our time frame and their time frame. I would ask those in the audience, please refrain from any type of comments, outbursts, anything along those lines as well. So we are going to start off and go in order. So I'm going to ask Miss Allison Adams from the Foundation for a Healthy Kentucky. Okay. We do have the overflow room, which is right next door, room 171. So I'm going to ask if you're standing to please make your way over to the overflow room where you can watch on video. So that's room 171, which is right next door. Thank you very much. And Miss Adams, if you would, please introduce yourself, your position, and you may proceed. It's not on, I think.
Got it.
There we go.
Good afternoon, Representative Lockhart and Senator Funky Fromeyer. I'm Allison Adams. I'm the president and CEO of the Foundation for a Healthy Kentucky. I want to thank you both for the invitation for me to speak with you today and to the rest of the task force. Oh, thanks.
Go ahead.
Go ahead. As she's moving on, I'll go ahead. My role today, as I understand it, is to present to the task force the health trends and the trending data in regards to Kentucky's health and Kentucky's health outcomes. The data I'm going to use today is a combination of the American health rankings as well as the behavioral risk factor surveillance system that is self-reported data from the CDC, as well as presenting you the annual report for Kentucky for not only the overall health, but also the senior report. I also think it's my role today to be the eternal optimist for you all as task force members and express my appreciation for you all to recognize that I'm not going to share any new data with you that does not reflect the fact that Kentucky's health has been poor and is poor and has been poor consistently, and that this task force has put together the charge to do something different about it. And so I appreciate that and the opportunity to set the stage as you move forward for recommendations. There we go. So overall rank in Kentucky is 41 in the nation, and we're 44th in health outcomes. We continue to face some of the highest levels of chronic disease, smoking, and preventable hospitalizations in the nation. You can see on this chart that our best grade was ranked 39th, and that was contributed to one of the factors that goes into the rankings, which was healthcare access. And I'll also explain a little bit about the conditions that move forward to develop this ranking of 41 and 44. The overall rank is considered when we factor in the health factors or the conditions in which people live, work, and play in the state of Kentucky. So that's where we get the 44th rank. The 44th rank is what's actually happening. So the morbidity and mortality in our nation, in our state, in regards to the nation, and especially when relate to the chronic disease diagnoses. Next slide I want to focus on is the premature death rate in Kentucky, which is alarming in respect to the loss of life prior years life lost of 75 years. So we are trending in the wrong direction in that as well. And as you can see by this chart, our premature death rate has worsened. And you can see that we're well above the national benchmark. And not only are we not improving, the benchmark or the comparison away from the benchmark is widening. Premature death is one of the things that, as a benchmark measure, we can see what policies and health implications can do to close this gap and allow Kentuckians to live longer, not only longer, but also quality of life. I also want to point out here that in the Commonwealth Fund scorecard on the state health system's performance in 2023, in every state, including Kentucky, there was a disparity that existed among Black Americans. And in every state, including Kentucky, Black Americans have a higher rate of avoidable death than any other person in any other racial or ethnic group. I want you to refer to your sheet in your packet. This is hard to read, but you should have a sheet in your packet. This is directly from the American Health Rankings. I want you to look at the dark blue lines there where it's measuring and giving you a ranking of the state to the nation in respect to the measures that determine or that go into our health outcomes. So you can see we're ranked 44th in the nation in social and economic factors. We're ranked 12th in the physical environment, 30th in clinical care, 38th in behaviors, and then you can see that contributes to the overall 44th ranking in healthcare. I also want to draw your attention to the top left corner here where it says drug death. We're trending in the wrong direction. This is based off of 2022 data in the 2024 report. And you've been told with the Kentucky Overdose for Death report, we are trending in the right direction. We're declining, and that's a great thing with all the concerted efforts that's happening towards preventing overdose death. It's just a lag in the data report from the American Health Rankings to Kentucky. So you have the good data collection in regards to opioid overdose. You have the power of knowledge for the what's happening currently in the state of Kentucky, and that will be reflected in the next America Rankings report. Also, you'll notice that in the red circles, those are gaps in data. This is because in 2023, Kentucky did not have enough respondents to the behavioral risk factor survey in order to be included, to have enough quality reporting and survey data to be included in this particular report. So now I want you to look, we're going to dig down a little bit with the chronic condition trends. So I want you to look about the rate of adults with multiple chronic conditions. This is one of the sections where you can see there's a gap in the data, but it doesn't really reflect or doesn't impact the trend lines. You can see that we also had a change in the methodology of the data collection, but the current trend and the connectivity between 2015 and 2021, there was no significant improvements in our trend, and you can also see that we consistently ranked above the national average. I want the task force and everyone in the room to take a pause in respect to what this actually means. These are Kentuckians who are suffering from 3 or more chronic conditions like arthritis, diabetes, asthma, heart disease, cancer, and we know that if you just have one of those diagnoses, how costly that could be, as well as loss of productivity you have as a person dealing with this. And this trend data is showing you that here in Kentucky, we have the highest rate of residents suffering from 3 or more chronic conditions. Costly not only to our healthcare system, but also to the individual and their productivity. And I want to turn our attention to the diabetes trends, which I know has a lot of interest with your task force in respect to healthy eating, physical activity. So I think it's important to recognize where we are trending with the diabetes. And again, I just want to note that little break in the trend line is change in methodology and lack of data for that 2023 section. But also you can see that almost always Kentucky was above the national average. And I can also tell you in that 2023 gap, according to the Department for Public Health, Kentucky Department for Public Health's 2025 diabetes report, 13.7% of adults in Kentucky had diabetes in 2023. Not reflected on this trend, but an interest to you, is the fact that we also are seeing discouraging trends in early diagnoses of prediabetes and diabetes in children, not to be confused with type 1 diabetes, which is a childhood onset. This is type 2 diabetes, which we used to consider as adult diabetes, is now being seen, diagnosed, and treated in children. I also want to talk about just the trend and the data that you're seeing. We have self-reported data. We have some clinical data that all marries into the America Health Rankings system. But we also know that there's cost and value that goes with it. So as we're looking to develop policies and we're looking to find just the right balance to measure what we're doing in the state in order to understand, are we making a difference with the policies that we're putting in place? I would encourage us to look at how can we defragment Kentucky's healthcare system's data from not only the outcomes, what's happening, what are the diagnoses, but what are the costs, who's paying for it, who has access, who doesn't have access, and looking at seeing where we can begin to build a more comprehensive healthcare system that shows and can demonstrate what policies are moving and how we're moving in the right direction. This slide is reflective of access to care as it relates to provider access. That means that a Kentuckian has access to a personal primary care provider in which that person has the ability to build a partnership, a relationship with the provider, so that that provider knows the patient's history, they know their family background, what constitutes their environment in which they're going in and trying to make the healthy choice. And you can see here the data doesn't look too bad, and if you refer back to your ranking, there's actually a number under the clinical care access where Kentucky ranks 16th. And that doesn't seem so bad, does it? We're ranked 16th out of 50. But what does that really mean? And when you look at the Kentucky Rural Health, the UK Center of Excellence in Rural Health report, they have determined that 43 out of 120 counties in Kentucky meet the criteria for a provider shortage area. So we have 43 counties out there that have a provider shortage in relation to a primary care provider. And that half of our primary care providers are working or providing services in Fayette and Jefferson County. So just two counties. I understand the most populous counties, but also just two counties is where over 50% of our primary care providers reside. I tell you this in respect to, this is an issue that is very local, and I'm hoping that it's a conversation starter with you on the task force and your constituents back home to really understand what are those barriers to actually being able to establish a relationship with the primary care provider. Understanding, is it transportation? We hear that. Is it that we just can't get an appointment? Is the distance too far? Is there a lack of trust? What is it? And I think it's a great conversation starter as we're making policy recommendations to improve that access to care in the state of Kentucky. Vaccines are another area where things aren't where we would hope them to be. This map is from the Commonwealth Fund's scorecard and state health systems performance. It shows the percentage of children ages 19 to 35 months who've received all recommended doses of the 7 key vaccines, which include protection against measles, polio, and tetanus. Kentucky is one of the worst. We're coming in at 64% of our 19 to 35 months protected. And that measure, as you can tell, and we've been talking about this for a while, it continues to worsen. And between 2019 and 2023, we saw the worst declines. This also shows you the kindergarten immunization and the sources from the Department for Public Health school immunization survey. The dark bottom line is the one I want you to focus on. It just represents the percentage of students who are fully vaccinated for their age group. And all of these lines are moving in the wrong direction, and we know that when we're thinking about preventing unexpected healthcare costs, hospitalization, loss of student and adult productivity, vaccines have that ability to reduce and prevent a vaccine preventable disease. So, we know that, at the Foundation for Healthy Kentucky and sister agencies, we've got to, in order to reverse this trend, we have to work on rebuilding trust in vaccines. And now I also want to just talk about the seniors. The American Health Rankings 2025 Senior Report is also in your packet. It looks very similar, but it's down at the very bottom. You can see that it indicates Senior Report. We rank 46th in the country overall and 49th in health outcomes in older adults. So we're next to last. To make significant changes, which I think we're all on the right track, we need to look at things that impact the future. We have to look at policies that support the health of young people, policies that are grounded in prevention, so that they age and become the state's workforce, they become the state's new parents, they become the state's new seniors. And they're able to move through life with good health that was established early on. I know this phrase has kind of been used several different ways by several different people, but this is a point to make, and where it's much easier to build healthy kids than it is to heal sick adults. It's also much cheaper to have healthy kids and support healthy kids than to heal sick adults. I want to just share a little bit briefly with the previous work of the Foundation for Healthy Kentucky. We fund demonstration projects. That's part of our role, one of the tools in our toolbox that we use. And our Investing in Kentucky's Future initiative has shown us what works when it comes to helping kids build lifelong healthy habits. When we contribute to the right investments, strong community partnerships, and supportive school environments, we saw real change. Kids were eating better, they were moving more, and they were building a foundation for a healthy future. The foundation stands ready to share that work with the MAHA committee in respect to seeing what counties in our communities were part of that demonstration project, and we're happy to share that as part of the work to moving forward. But also, we just can't focus on food. We also need to make sure that there's access to physical activity throughout their day, and that includes the built environment where kids are living, where they're playing, where they're learning. And so just encourage you to consider not only food, but also physical activity and education. Just to wrap up, we know that if we want to become better Kentucky as adults and better Kentuckys as seniors, I think this is a stark report and a call to action in respect to our rankings for our senior health outcomes. Investing in health of younger generations, preventative care, strong community supports, healthier environments, and early interventions, they're not just strategies for the future, they are urgent needs for our present. As you look at these trends and you think about strategies, again, thinking about not just focusing on food quality and food access, but also recommending the necessary investments that provide communities and schools with resources that can help kids and families build lifelong healthy habits. We can expect people to make, and their families for that matter, the healthiest choice if they don't have enough supports and opportunities to do so. So in conclusion, I want to thank you for the opportunity, and to you and to the room, when we report data and stats, it's important to remember that these aren't just data and stats. They represent the stories about health and well-being of our neighbors, our family members, and our communities, and everyone who's in Kentucky. Kentucky's health challenges are serious, but again, back to being the eternal optimist, I do believe that it's possible to make improvements when we all come together and work together. Again, thank you for your time and commitment to this work. And I want you to know that the Foundation for a Healthy Kentucky, Rep. Lockhart, and Senator Funky Farmeyer, we stand ready to continue to advocate and support for the unmet health needs of Kentucky.
Thank you so much. We certainly appreciate your testimony. It's good data. It's not heartening data, but it is a lot of work has gone into this. So thank you so much. I believe we do have a question from our task force. We'll start with Senator Funky Farmeyer.
Thank you so much. That was such a meaningful overview of why we're even sitting here today. On your slide about the multiple chronic condition trends with 3 or more, what is the age range of those that were tracked?
So the age range is just if you have a diagnosis. So if you are a Kentuckian, it doesn't matter how old you are, if you have 3 or more chronic condition diagnoses.
So you could be that kindergartner or you could be that 89-year-old?
Yes.
Okay. And then do we know of those that have 3 or more diagnoses, are they actively employed?
I do not know that. So I don't know. I don't know if that's a measure in respect to the data that they're collecting to put into this report.
Okay.
But that's a good question.
Yeah. Okay. Thank you.
I would just say that this, again, another plug for data in respect to understanding, if you have insurance and you have 3 or more chronic diseases and you're employed, there is a way to find that data in which you can identify that they are employed and they are dealing with 3 or more, or not employed and dealing with 3 or more chronic diseases. Again, that fragmented of data that we could recommend as a policy to pull us all together.
Mm-hmm. Thank you.
Are there any additional questions from the task force? I was actually going to ask you on the diabetes trend slide where you mentioned that 13.7% of Kentucky adults had diabetes in 2023. Is that type 1, type 2, or both?
I can't answer that question right now,
Okay.
but I know I'm just afraid I'm going to misspeak.
Yeah, that's okay.
But in respect to the report, it is a Kentucky Department for Public Health generated report. And I know that a lot of the work is focused on type 2 diabetes here in the state of Kentucky. Mm-hmm. So the trend is most likely type 2 diabetes, but please, I can refer you and get to the complete report.
That would be great. Thank you.
To know that for sure.
Thank you. Any additional questions? All right. Thank you, Ms. Adams. We appreciate your testimony. We are going to back up on our agenda just very quickly for the approval of the minutes from our last task force meeting. A copy of those should be in your folder. I will entertain a motion to approve those.
Motion.
Motion and seconded. All those in favor?
Aye.
Aye. The minutes are approved from last time. All right, so we are going to jump into a discussion of SNAP benefits, some different facets of SNAP. I'm going to ask our next guests from the Cabinet for Health and Family Services, if they come to the table. Ms. Dennis and Mr. McCann, if you would, please introduce yourselves, your title and position, and you may proceed.
Good afternoon. My name is Lisa Dennis, and I am the Commissioner for the Department for Community-Based Services.
And I'm Roger McCann. I am the Director of the Division of Family Support within DCBS.
Just a quick reminder as well, we have a lot of presenters today and only a short amount of time, unless you all want to have dinner here tonight, which we are not providing that. So we will need to be short with all of our testimony. So please proceed.
Again, thank you for the opportunity to be here this afternoon to talk about SNAP, the Supplemental Nutrition Assistance Program. I think we all know that our diet influences our health, but it also has an impact on chronic disease. Poor diet is the leading cause of death in the U.S., and it drives chronic diseases like type 2 diabetes, cardiovascular disease, obesity, and some cancers. We often think of poor nutrition as a health issue, and it is, but it also impacts families and communities in other ways. Being without food, families experiencing hunger, doesn't just harm physical health, it can also lead to family stress, instability, and child welfare involvement. Research has shown that the lack of food, which is, again, a basic necessity, is a strong predictor of child neglect. Approximately 70% of all CPS allegations, both in Kentucky and nationally, are related to neglect, and the majority of those referrals are connected to poverty. Now, we know that poverty is not neglect. Just because someone is poor does not mean that they are neglectful. But when we see unmet needs, such as lack of access to food, families again experiencing hunger, we see the increase in the risk of abuse and neglect. There has been a number of research studies completed that has shown the connection between food and child maltreatment. Here we have one such study that shows that states with more generous SNAP policies experience significant reductions in Child Protective Services reports, fewer substantiated reports, and fewer foster care placements. Which, again, food is prevention. Here we have a study completed by Chapin Hall that found that for every 5% increase in the number of families receiving SNAP was associated with an 8 to 14% reduction in Child Protective Services and foster care caseloads. Now, in these slides, we have highlighted the impact of food and nutrition on children, child health, and child well-being, but we could have easily provided similar data for other vulnerable populations, older adults, individuals with disabilities, pregnant women, etc. Again, food and access to food is essential, as we all know, for all populations, all demographics, all age groups. All Kentuckians deserve to have access to an ample supply of healthy and nutritious foods. And access to nutrition support through SNAP helps reduce risk and promote stability across all groups. So here we see on this slide the different components of SNAP, and Roger's going to take you through each of these in more detail in just a moment. The component of SNAP that we're probably all the most familiar with is the financial assistance to eligible low-income individuals and families to help with the purchasing of food. We currently have a federal funding to support a SNAP education program, SNAP outreach, SNAP employment and training. I will mention here that with the passage of recent federal legislation, that legislation eliminates federal funding for SNAP Ed, and that will be effective as of the federal fiscal year 26 or September 30th. And this is one of the few resources focused on nutrition, education, and budgeting for low-income populations. And currently, the federal funds for SNAP Ed is administered through the University of Kentucky and distributed to the local county extension offices across the state. And Roger's going to share more.
Sure. Well, thank you very much, Committee and Commissioner. Appreciate being here today. This is important work, and we're glad that you invited us. As the Commissioner said, SNAP Ed, SNAP Education, it's the nutrition education component piece of the USDA's SNAP offering. It has been important because it helps build those healthy eating habits. It is administered through the University of Kentucky, and it's cooking classes. It's going out to schools and libraries and teaching people how to use fresh fruits and vegetables, and also how to do it on a budget. And so we are aware that this program is being eliminated. We have reached out to FNS, and they've not given us any guidance at this point about how it would wind down, or what might replace it. So we're hoping that there is some sort of nutrition education piece there. But we leave it in here because it's important. It did have 3 different components. First of all is the education piece, the cooking classes, like I mentioned, social marketing, so just getting information out about healthy eating, and the University of Kentucky would do that through social media, through sort of advertising events and things like that. But then there's the other piece, the policy systems and environment. These are the things that make eating healthy the easy choice for folks, making sure that they have access to a SNAP retailer that has fresh fruits and vegetables in it, for example. And so those were some of the big components of it. The next component I want to mention is SNAP outreach. Now, SNAP outreach is typically administered through nonprofits. They have to match 50% of the federal funds. So with SNAP outreach, it's a 50-50 match. And they are typically organizations who are in contact with folks who have hunger, food banks, food pantries. And they would see folks and they would be able to guide them and tell them about SNAP, how it could assist them and their family, and how they might be able to use it to make healthy choices. Outreach is still intact. The third component I want to mention, and you may say, well, what does this have to do with eating healthy? But it's very important. This is SNAP employment and training. This is another component that is federally funded by the USDA. There's 2 different funding streams in it. But what it does is it's job training. So an example would be a recipient of SNAP goes and gets some education or training. That training can be reimbursed by the USDA 50%. So as long as the initial funding, the match funding, is non-federal. So for example, if state funds were used to train somebody, to get them job skills, then the USDA, if they're eligible, the USDA will be able to match those funds. We have been building this program out. We do know that work requirements will be changing with this new bill that's been passed, and we are preparing our partners and providers to be able to do the types of training that will help people get jobs. Why does USDA do SNAP employment and training? Because the best way to overcome food insecurity is through a job or a better job. And so the idea behind SNAP employment and training is to help people who utilize SNAP become income ineligible, to have enough money that they're no longer eligible and they're able to stabilize and no longer need that. And then by resolving that food insecurity through income, they can eat better and have better nutrition. So that's why that's been there. As I mentioned, the USDA will reimburse up to 50% of job training. One thing that we have not done in the state of Kentucky that we're preparing to do right now is utilize subsidized work-based learning. So actually, when people do work-based learning on the job, the USDA will subsidize part of that income to encourage them to go into the job market. So I mention this because I think it's a really important piece that's sometimes overlooked out there. Getting back to SNAP for a moment, I brought some June 2025 numbers for you. In the state of Kentucky, 280,771 active SNAP households. We do see that fluctuate month to month, largely because of economic conditions. About 562,000 individuals are receiving SNAP in the month of June. And remember that it is a household program. It is a household benefit. It benefits everyone in the household. So it's not given to individuals. It's designed to affect everybody in that household. In June, $96 million worth of SNAP issuances. That is currently federally funded. As the Commissioner mentioned, with the passing of the H.R. 1, there could be for states some cost sharing that will come into play, and it will depend upon some of their error rates and things like this. We're currently evaluating that, but right now that number is currently federally funded. The average SNAP household in Kentucky, $343 a month. The next slide, I've just got some brief breakdown by age. 39.28% of the folks that receive SNAP that live in a SNAP household are under the age of 18. In June, that was 220,000 folks. I also would like to point out that 16% are 60 and over, so that's 91,000 there. Just giving you some brief numbers there. Next slide, I want to point out that, and I just pulled this off, this is publicly available data from the USDA. This is a breakdown of our retailers in Kentucky that offer SNAP. Convenience stores, farmers markets, grocery stores. I get a frequent question about that, is a store that's primarily not selling food, but also accepts SNAP. An example would be CVS, a Walgreens, a Family Dollar. They're there established to do other things, but they accept SNAP as well. And those are categories that the USDA puts them in. 4,616 retailers, so the $90+ million goes to those retailers when they make those purchases. We do have some great opportunities. Through your all's work, through our work, we have the opportunity to improve the health of Kentuckians through nutrition. You just heard Ms. Adams talk about data. We are looking very closely at, because we're at the cabinet, we can see Medicaid claims data. And what we're doing is we're matching that up now to see if those folks are utilizing other resources like SNAP. So for example, we can look at the claims of a senior who has diabetes, who lives alone. If they have food insecurity, are they utilizing SNAP? If they utilize SNAP, are their claims lower or higher? And what we want to do is see if we can utilize a program like SNAP to help bring Medicaid costs down. And we have the ability now to do that. We've just started this data study. We hope to have some results soon. And what we're doing with the data is we're talking with our managed care organizations about maybe how they could use this data to inform them, to reach out to their members and find new ways to improve their health. We're very early in this, but I think it's exciting work that we're doing. We've also done some things to help, for example, MCOs provide prescription food boxes, medically tailored meals. We know from data from our partner at the University of Kentucky that when we provide medically tailored meals, prescription food, nutritious food to folks with hypertension, diabetes, we see those symptoms go down within 90 days. So we have that information there. So we're interested in how we can leverage, for example, Medicaid to purchase food for those folks and use it food as medicine, for example. There's some other things I want to mention. Louisiana has a very interesting pilot that we're watching closely. So what they're doing is in 6 parishes, when people use their EBT cards at a Walmart to buy produce, fresh produce, they get 30 cents for every dollar, and it's put back onto their card. They're capped at $25 a month. This is an incentive program to get folks to purchase healthy, nutritious food. In Kentucky, we are very interested in programs like the Double Dollars. So the Double Dollars program encourages folks to purchase locally grown produce that's grown here in Kentucky at farmers markets, and by doubling their EBT dollars. So it allows them to stretch that budget. So I just want to mention some of those opportunities. The last thing I want to mention is some of the efforts we've done about fraud, waste, and abuse. Kentucky is one of the first in the state first in the country to join the NAC. It's the National Accuracy Clearinghouse. And what that does is, let's say someone went to Illinois and received SNAP. If they tried to receive it in Kentucky, there's a data matching agreement now. So we can verify, are they receiving in another state? If we find someone who's receiving duplicate benefits in another state, we can resolve that through a process through the USDA. That prevents somebody from being able to get double benefits. So I wanted to emphasize that we are already on board with that. Ours is up and running. Other states are, I won't say lagging, but they have until 2027 to get theirs in place. So that's a brief overview of SNAP and some of the things we're doing at the cabinet. Would entertain any questions.
Yes, thank you so much for your testimony. I actually have a question for you. You mentioned just now the opportunity page there, and at the bottom, the Double Dollars program that Kentucky has. Is there any tracking of that to know how many people are utilizing that, what the benefit of that has been?
I would not have access to that because that is actually operated by the Community Farm Alliance. We could certainly ask if they could get that data. It's not something we see on our side of it.
That would be fantastic to to actually have that and to incorporate that with the data study that you're doing along with the SNAP dollars and Medicaid as well. Are there additional questions from the committee? Senator Douglas.
Thank you, Mr. Chairman. I just have one, and I'll make it brief. I'm looking through some of the data that we're looking here with a supplemental nutritional assistance program, and I saw some of your data on the breakdown in terms of age, those who are utilizing the program. One of the things I'm looking for also is some of the data on, and we also looked at some of the institutions or the stores that actually offer or take SNAP. Are we also collecting data on where the recipients are most likely to be using this program money?
Is your question related to where are, for example, what counties? Or
No.
or-
It's simply related to those stores that the money is actually being used in. I know there can be a difference between which types of stores actually will receive or take the benefits. But what I'm interested in is how our recipients are actually utilizing, where they are actually utilizing those benefits.
I see.
Thank you, Mr. Chair.
I do not have access to that data right now, but I can ask our and see if we can get that data. Those transactions are handled by a processor, and they would have probably access to be able to show where that information, where those funds were being spent. I do not have access right now to that.
Thank you very much. Thank you, Mr. Chair.
Yes, sir. Senator Wheeler.
Thank you, Mr. Chair. And I think in your testimony, you hit a little bit on a thought I was just discussing with my colleague sitting next to me. But, obviously we need to help kids and families in need. I think anybody on this committee would agree with that. But, we live in the 21st century with AI and all kinds of computer programs and wonderful tools that help us organize and manage. Why couldn't we, essentially program these cards to where, for example, maybe there's a base of, say, just hypothetically $500 a month, but if you swiped it and bought the right things, like what we're talking about here, you get $750 worth of benefit, kind of like what you see in Louisiana. That would, kind of encourage people to utilize that stuff on I think there would be probably savings over time with that. And I guess secondly, on the educational component you're talking about, I see you give a figure of $96 million for SNAP issuances. How much is actually spent on that educational program that you said is administered through UK?
So SNAP-Ed is a separate, so that was referring to the benefits that are placed on the cards. SNAP-Ed is a separate funding stream
How much
from
is
USDA.
it?
Yes, sir. And in the last few years, it's been about $11 million annually to the state of Kentucky.
But okay, so $11 million.
Yeah, and those are two separate funding streams.
Okay, and I apologize, Mr. Chair, if you'll briefly. So of that $11 million, how much of that actually goes towards beneficiaries, or how much of that actually goes towards the university and like administering these programs?
Oh, I see. I don't have that breakdown. We do have a budget that is supplied that we have that breakdown. I did not bring it with me today. It is done through the 120 county extension offices. Are the folks that then administer that locally in every one of the counties.
Does it actually give out food at all?
No, it does not. As a matter of fact, they're prohibited from doing that. They are only supposed to be doing nutrition education.
So we're okay. All right. Well, I'll let you go ahead and ask that. Go ahead.
Representative Duval.
Thank you for your presentation. How much would it cost the state to manage SNAP if a waiver is approved by the federal government? What do you estimate?
A waiver. Not sure what your
So our percentage,
our admin cost.
Yes. What do you think that's going to cost?
Currently, the admin cost is 50-50, 50% state, 50% federal funding. And with the passage of this legislation, that will go from 50-50 to 25-75. So the state will be responsible for 75% of that admin cost, which we estimate to be approximately $66 million additional cost to administer the program.
Okay, thank you. And also, can you speak to the error rate? You'd mentioned that earlier, about that impacting everything. Could you describe that?
Yes, so states will have to contribute a state share to administering the program if their payment error rate exceeds 6%. That contribution will either be, either be 5%, 10%, or 15%. So if you're below 6 or below, it's 0. If you are 6 to 8, it's 5%, 8 to about 9.9, 10, that's 10%, and then 10 and above would be 15% of the cost sharing would be to the state.
Okay, very good. Thank you.
All right, our last question comes from Senator Tishner.
Thank you. Senator Wheeler was getting along this line and passed it off to me to keep asking more questions.
One question.
Oh,
question.
just one?
Just one. Time.
Oh, administrative cost of SNAP Ed, you don't know that number. I'm going to not ask a
That's
question.
a good way to not ask a question.
Because I want to get another
We can
question.
get that.
We're typically allocated around $11 million per year from the USDA to operate the program. It's under contract through the University of Kentucky. I do not know the number, the ratio of admin to services provided off the top of my head, and would dare not guess it. So I would be happy to provide you that information and that breakdown. We do have it. I just did not bring it with me today.
Okay, that would be wonderful. I think that'd be really helpful as we look at the federal numbers coming to the state dropping. I appreciate that.
Thank you so much. We appreciate your testimony.
Thank you.
Thank you.
We will be moving on in our agenda with the organization End Chronic Disease, and I believe they are going to be joining remotely. Is that correct? I'll wait till they get on. Is Ty here? Is Ty Beal?
I'm here. That's right.
Okay.
And Kelly's going to start us off here.
Okay.
And I will.
We can hear you. We can't see you yet, so hold on just a second.
Okay.
Kelly's here as well. Hopefully you can hear me.
Yes, we can hear you as well. I will tell you both as well, we are running short on time in a time crunch. So if you could keep your comments very brief.
Chairman. How much time?
Probably around 10 minutes.
Perfect.
Is Alan here? Alan in person? Yes, sir. You can go ahead and come to the table if you want. Are you with them as well? I am. Okay, very good.
Chairman Lockett, if I could record my presence as well.
Yes.
Thank you.
Thank you, Representative Callaway. If you could go ahead and talk, maybe it'll grab you on the screen.
Yeah, I can
There
start.
we go. Perfect.
All right. Well, good afternoon, everyone. It's an honor to be here, at least remotely. I'm sorry I couldn't make it in person. My flight was unfortunately canceled. Thanks for your great leadership in convening this important task force, and thank you for having me and Ty here today. My name's Kelly McKenna. I'm the CEO of End Chronic Disease. We're a national organization confronting the most urgent public health crisis in America, chronic disease epidemic. Statistically speaking, with an estimated 60% of US adults having at least one chronic condition, it's more likely than not that any of you in this room has or will develop at least one of these illnesses, likely multiple. If not you, certainly someone in your family will. And if you have kids, they're even more likely. The good news is prevention is possible. Chronic illness is not random. As you're all aware from the MAHA report, scientific research shows that a vast majority of these illnesses are driven by a handful of the same factors: poor nutrition, sedentary and stressful lifestyles, environmental toxins, and a health system that is not root cause focused. All of these drive metabolic dysfunction and subsequent disease development. As someone who has personally reversed 2 chronic illnesses through addressing these root causes and weaned entirely off of a daily prescription, I've experienced firsthand the innate power of the human body to heal itself, and I'm far from alone. Countless other Americans have also reversed chronic illness through the same measures. The truth is, for most Americans living with chronic disease, remission is within reach, and we formed End Chronic Disease to help them reach it. We've convened a coalition of experts from the scientific, medical, and business communities who represent the forefront of prevention-focused health innovation and reform. I'm honored today to have one of these experts with me, Dr. Ty Beal. Before I turn it over to Dr. Beal, let's take a quick look at nutritional intake and chronic illness in the nearly 13% of Kentuckians who rely on SNAP each month for nutritional support. Numerous studies show us that SNAP participants are getting more than half of their daily calories from ultra-processed foods at rates that are meaningfully higher than non-SNAP participants, regardless of income level. These foods are strongly linked to illness. Even more concerning, the same research also shows us that sugary beverages alone, which contain 0 nutritional value, are the #1 grocery expenditure among SNAP households in the US. And SNAP participants are consuming as many as 7 of these per week, compared to 5.4 per week for low-income non-SNAP recipients and 3.8 per week for higher-income non-SNAP recipients. Population data also confirms that SNAP participants have higher rates of chronic illness, like diabetes, obesity, and heart disease, than their non-SNAP counterparts, again, regardless of income level. These health consequences are well understood at a biological level. They're not theoretical, and it's evident in your population data. Of course, part of the challenge stems from decades of food innovation that have made the most harmful foods in our food supply among the most desired and the most affordable. But that's nothing that better innovation can't solve for. And fortunately, we're starting to see major food and beverage companies lead with innovation. They're prioritizing investments in making nutrient-dense and metabolically balanced foods and beverages more desirable and more accessible. As President Johnson said when the food stamp program was launched in 1964, this program is one of our most valuable weapons for the war on poverty. With your help, the same program can also be one of our most valuable weapons for the war on chronic illness. With that, I'm honored to introduce you to Dr. Beal, a world-renowned nutrition scientist and head of food systems data and analytics at the Global Alliance for Improved Nutrition. Dr. Beal brings deep expertise in public health, epidemiology, and food systems, with a specific focus on how diet quality, food processing, and access to micronutrients impact chronic disease. Dr. Beal is widely published in scientific journals, regularly contributes to global health conversations, and is passionate about making nutrition science accessible and actionable. Serving on advisory groups for the World Health Organization, UNICEF, and the UN, he's also no stranger to the concepts of food insecurity. With that, I'll turn it over to Dr. Beal, and thank you.
Thank you, Kelly. And can you all hear me and see the screen?
Yes, sir, we can.
Excellent. So I'll just get started with a few slides here. I'm going to talk about ultra-processed foods and how they drive chronic disease. So this photo here, you can see many of these ultra-processed foods that we're familiar with. So what are ultra-processed foods? Well, they are industrial formulations made entirely or mostly from substances derived from foods and additives. So these foods are formulated by industry, and they typically are high in calories, so energy dense. They're typically nutrient poor. They're typically very, very refined and processed. Now, this system is not perfect, but it does indicate a group of foods that is risky for our health. Now, what do these foods really cause? What have they been linked to? Well, just about everything in terms of chronic diseases. We see all-cause mortality, so just early death, so death from a chronic disease, obesity, heart disease, type 2 diabetes, cancer, and so on. I won't go through all of these, but numerous studies, and these are systematic reviews after systematic reviews, which are really looking at a big suite of studies, numerous studies in different populations groups, and they all point to the same thing. Many of these foods are very risky to our health. Now, there's one study in particular that was conducted by Kevin Hall at the NIH and published in 2019, which was a randomized controlled trial. Now, this is a unique type of study design that is very rigorous. It's very much linked to understanding the causality of things. And so what was done is individuals were sort of assigned to this group of unprocessed diets. So that's the picture on the right. Fresh foods, fresh vegetables, some lean meats. On the left, it was ultra-processed diets. Now, what's really interesting is that he tried to match these. The team really tried to match these different diets in terms of calories, in terms of carbohydrates, in terms of fat, even sugar, sodium, and fiber. So it's not just the nutrients in these foods. It's not just the nutrient content. It's something about the processing. So what happened here? Well, very rapidly, you see increased intake of these foods. Now, this study allowed individuals to eat as much as they wanted and to stop when they felt full. The blue line shows you the ultra-processed group. Over 500 calories more consumed each day compared to the group in the unprocessed diet. What happened to the weight gain during this time period? Well, you can see rapid weight increases starting at the second, third, and fourth day, becoming very significant. So those on the ultra-processed diet gained weight rapidly. Those on the unprocessed diet lost weight rapidly. So what is it about these foods that are problematic? Well, we're still learning, but we know quite a lot. These foods are very rewarding. They're desirable. They're addicting. They're hard to stop eating. This is called hyperpalatable. They are not satiating, so they don't make us feel full, so we can overeat the amount of calories we need because they're not really satiating us. They're low in synergistic vitamins, minerals, protein, and all sorts of beneficial bioactive compounds, as well as fiber. So they displace more nutritious foods and cause and lead to inadequacies. So they also contain potentially harmful additives and contaminants produced during processing, which can have disruptions to the microbiome, which we know is very important for health. It can lead to oxidative stress and inflammation. So I just will close by just wrapping up some key potential policy changes. And of course, we're talking about SNAP today. And so one of those for consideration, which other states are considering as well, is do we restrict sugary soft drinks in SNAP? Like Kelly said, these drinks have zero nutritional value and only nutritional risk, right? Very directly linked with type 2 diabetes and obesity. There's other things we can do. I won't go through all of these, but potential taxes on certain things like soft drinks, subsidizing minimally processed foods, designing packaging differently, restricting marketing to children. You know, many countries, most countries around the world have restrictions on which types of foods can be marketed to children. In the US, we do not have many restrictions. There's a lot of room to improve there. A huge impact here can be through limiting ultra-processed foods in schools and in public institutions. So this can be done through policies where this lever of procurement can have a huge impact on the amount of funds going towards these products. And it can change the situation so that more affordable, healthy foods can be available, and it can reduce the price of those. So there's a lot of other things here, but because of time, I'll stop there, and happy to answer any questions that we have time for.
Thank you, Kelly and Ty. We certainly appreciate your testimony and your time. Do we have any questions from the task force? Representative Callaway?
Thank you. That was some good information. I had a quick question about the formulation and the processing practices. That was one of the recommendations. And I've just heard, I'm just going to say rumored, so I just kind of want to hear your feedback. A couple, 2 or 3 different types of shots have become popular to combat obesity, cravings. And the rumor that I have heard, that I'm trying to substantiate or not, or just get your take on, is that scientists have actually been brought in now to process foods that can combat or counteract whatever immune attributes that these shots have. The urges, the cravings. So they're kind of trying to change the formula so that the shots will not affect their industry. Have you heard that? Is that outside of the realm of possibilities?
Maybe Kelly's heard of that. I have not heard of that. I'm not aware of that happening. These drugs, which are called GLP-1 agonists, are very effective in trials so far with helping people reduce their calorie intake. They're not a panacea or a silver bullet. They're typically recommended in conjunction with diet and lifestyle changes as well, for a lot of reasons, for overall health. So I think they're one important tool in the toolbox, and they're very expensive in the U.S. right now. We've heard from the NIH director, Dr. Bhattacharya, that they're working to reduce prices for these types of drugs and other drugs. So I think that that's going to play a role in the future. But diet and lifestyle are really critical, and they're not going away. They're going to be important for health for the long term.
Can I follow up just quickly? So we know the processed foods do increase craving. Your charts show that they increase hunger, the cravings. They want to eat more of the processed food. So apparently, somewhere in that formula, there is some interaction there with the way that we crave food, obviously. So you're saying that that's not possible. That's not something that you think they could be working on.
Just to understand your question, are you saying that the drugs, these GLP-1 drugs, can you eat an ultra-processed diet and still lose weight? Or
well, I'm saying, do you think there's a drive in the industry? Are they feeling so threatened in the food industry, in the processed food industry, that they would pursue avenues that would make those shots ineffective?
Again, I haven't heard that, but I think what we need to think of a bit more is how can we work together so that we can still have successful businesses? So whether that's reformulating, divesting from certain product portfolios, I think that's the way forward. If industry does have plans, yes, industry can be very clever about overcoming certain things. So for example, if you put limits on how much saturated fat, how much salt, those types of things, industry can still produce really, really palatable, addicting foods that fit within those limits. I have not heard of industry being able to produce foods that will completely be resistant to GLP-1 drugs. That's not something I'm aware of, and I'm not sure if that's just that I'm not aware of it. But
I'm glad to hear you say that. Thank you. Thank you.
Senator Douglas.
Thank you very much, Mr. Chair. I just wanted to express one concern. Taking a look at the study that you had cited and looking at ultra-processed diets cause increased calorie intake, or at least X number of increased calorie intake. I just want our people to understand we have to be very, very careful with the words that we use and the narrative that we put out. I may accept the word stimulate or even correlates with, but the study that we talk about, specifically what jumped out at me was they were allowed to eat whatever they wanted. So there really was no standardization to be able to compare those groups on a fair basis, simply because the volumes or the amount of foods weren't monitored. So I just want to make sure that we don't use the word correlate, which is in fact, as opposed to say things like stimulate, or we don't say cause, because causality is a big deal. It's a big deal. but correlations and simulations, those words are a little bit better. I just wanted to say that, Mr. Chair.
I think it's important to understand this study design, right? So this was a design that is intended to identify causality. Now, what's important, the nuance here is that these diets were 80% ultra-processed versus 80% unprocessed. So they're very intentionally very different types of diets. But the design was set up so that individuals can eat as much as they wanted by design. The reason that was done is because in the real world, individuals in our food environment in the US, we typically have access to as many calories. And you look at the consumption of calories, we consume much more calories than we need. And so this study was designed to be able to determine this causality. Now there are issues of how long was this study done, replicability. Now there have been other studies. There was one in Japan just last year that replicated this study and still found this. The thing that makes me concerned is that the observational data, which you use this word correlation, right? That doesn't indicate causation. That indicates there's a relationship. So many of the studies on the slide I said about diabetes, heart disease, those are correlations because we can't really detect whether it's which direction that relationship exists. But the combination of the observational studies showing correlations which indicate some potential concern and the randomized trial indicating people on these really ultra-processed diets do consume too many calories, that makes me concerned as a scientist. And I understand there's different perspectives, but that is something that I'm concerned about.
I agree. And my perspective as a scientist as well is that the other variable that we're not talking about is a personal choice. Even though we're more stimulated, there are people who are stimulated in different capacities or other avenues, but they make that choice not to do that. So I think it's very, very important that we at least allow our public to see the big picture, and causality is much different than correlate and stimulate. That's my point, because we still do have the variable of personal choice.
Yeah, and to go along with that, it's very important that genetics play a big role. So two individuals can be in the same diet, and one can overeat and one cannot overeat, and that's largely driven by genetics. So your genetics can increase your risk or susceptibility to these foods. Some people can not overconsume and others can. And the reality is that many of us are vulnerable to this, and we know this because of the data, because of the prevalence. Obesity is at 43% in the US, very high.
Yeah, I agree with the results of the study. I just want to make sure that we are very clear in the narrative that we are using to get others to understand that link. That's why I make these comments.
Thank you, Senator. Our next question is from Senator Funky Fromeyer.
Thank you so much for this insightful presentation, Dr. Beal and Dr. McKenna. Very helpful. So as I'm considering calorie, but I'm also considering where ultra-processed may have calories, but just a steak and broccoli may have more calories than what was in fact consumed. So I'm looking for how are we offering a more trackable, traceable way for a person to know that they're on the right track, that they're eating the right things that are minimizing their incidence or potential towards chronic disease. You've mentioned a number of things, and I think as simple as a protein, a fat, and a carbohydrate. But how and what direction are you seeing us take, and are there meaningful tools that we need to be thinking about too? And I'm thinking of course, ways of measuring our carb overload and such.
That's a good question. You know, there are many ways to go about it. I think we need to keep things simple for the general population. If we overcomplicate things, the communication, the messaging is going to be challenging. So eat minimally processed foods, right? Or eat fresh foods, or eat whole foods. Those types of statements, I think, are easy for people to hold on to. And then we can get into the nuance in different contexts when individuals are open to that. Now, certain tools we have potential software applications, right? People can track what they're eating. There are tools like Hava, which is an app that's available that kind of tells you which foods are more satiating. There's AI that's used that you can take a picture of a food and it can kind of put in the ingredients. It can tell you what's in it, and it can help you give a score. There's packaging, right? The packaging can indicate whether those are healthier foods or less risky. I think the thing is that we need to pursue all aspects simultaneously. We need to make policy changes. We need to educate the public. We need to have tools and software. We need to have all sorts of things, right? The procurement, all of that plays a role, because right now these foods are cheap. They're accessible everywhere. They're obviously tasty and desirable, right? Other foods, fresh foods, are sometimes more expensive. We need to shift the policy landscape so that these foods, healthy foods, are the easy option. Placement in grocery stores, when you're shopping, advertising, all of this stuff. And like Kelly mentioned, the food industry is amazing at advertising, right? Let's use that for good. You can advertise healthier products. We can change our product portfolios to be, produce satiating, nourishing foods. We can have these foods that are still, processing is not bad in itself. It's excess processing.
So Ty, I'm going to kind of use your testimony in terms of a springboard into our next portion with this question. A lot of the issues that we deal with and kind of look at on a statewide basis, we can talk about eating fresh food. We can talk about having access to fruits and vegetables and non-processed foods. The bottom line is we have parts of our state that do not have access to some of those. And so a lot of the conversation revolves around, it's great for people that, may live in Lexington and Louisville and can go to the grocery store on the corner. But if you're in certain parts of our state and the nearest grocery store is miles away and you might not be able to get there, the closest place to get food might be a Dollar General, which is chips and Cokes and snacks. How would you say that with that issue, how would you say that we go about kind of looking at that issue, maybe some policy suggestions around that, when we have clearly kind of two different areas of the state, one that would have easy access to the foods that we know that are best, and then possibly other areas of the state that do not?
Yeah, I can let Kelly come in here if you have ideas, Kelly. I think I can just start by saying, with the specific idea of these grocery stores, you're absolutely right that these are often called food deserts, where surprisingly in the U.S. in 2025, we actually have many populations that are not near a grocery store. I looked at that SNAP chart on the previous presentation showing that most of these SNAP places are convenience stores, just like you said, where there may not be any fresh fruits and vegetables available at that store. So we need to incentivize. Can we incentivize, producers of grocery stores to build grocery stores? Can we incentivize the production of these foods at a cheaper level? Can we incentivize industry to start promoting these? It has to be synergistic. I mean, that's just some ideas from the start. But I don't know, Kelly, if you have any more to add.
No, that's something we can follow up with for a later hearing.
Yeah, that would be good. Just some ideas kind of that you may have around that as well. But thank you so much for your testimony. We certainly appreciate it. With that, we will call up Jordan from Feeding Kentucky, and to look at these food deserts as we've just begun talking about. So Jordan, if you would, state your name and your title, who you work for, and please proceed with your testimony.
My name is Jordan Ogile. I am the advocacy manager for Feeding Kentucky, and I want to start by thanking the committee for having me here today, Chairwoman Fromeyer and Chairman Lockett. I appreciate the soft pitch to start this presentation with your question to Ty. And I also want to acknowledge that before we convened, Representative Duval expressed disappointment. I'm not here to discuss food desserts. I'm here to discuss food deserts. So I'll be talking about access across Kentucky today, and I'm sure those sugary treats will come up. But I want to focus on a quick introduction to who I am, what Feeding Kentucky does for the state, and how food security across the Commonwealth looks. So, Feeding Kentucky, as a general introduction, is a nonprofit, bipartisan. We are a partner state association to the National Office of Feeding America. We are one of many partner state associations. Our mission is to work collaboratively to end hunger and to create a hunger-free Kentucky. And we work with farmers, we work with school nutrition folks, we work with the state when it comes to administering SNAP, and we work with you. We work with policymakers to pass legislation that we think will go a long way to creating food security across the Commonwealth. So I would love to start with a definition, or rather four, of how we quantify and qualify food insecurity. The United States Department of Agriculture has 4 levels, starting with high food security, which most of us likely experience, where there are no reported indications of food access problems or limitations. And then it trails down to very low food security, where there are reports of multiple indications of disrupted eating patterns and reduced food intake, with a spectrum between the two of them. And you can see this 2023 chart expresses what those limitations might look like. Whether you're worried that your food would run out, whether the food that you bought doesn't last long enough, if you couldn't afford a balanced meal, or if you had to skip meals. And there are gross disparities between food secure populations, low food secure populations, and the very low food security populations. So hunger does not have a single face. It does not look identical to everyone experiencing it, and it manifests in very, very different ways. I would first point the committee to Feeding America's national analysis of hunger that is released on a yearly basis, on a 2-year delay. So our most recent data report from 2025 gives us our first glimpse at 2023. Quite appallingly, 1 in 5 Kentucky children are food insecure. We have the second highest rate of hunger nationwide in the age bracket 50 to 59. And we have 4 counties in Kentucky that rank nationally when it comes to food insecurity rates. So if you pay attention to the chart on the right there, we get our glimpse at how over the pandemic hunger evolved. And kind of counterintuitively, hunger decreased for most demographics in some shape or form over COVID. And that's because the government rolled out a bunch of supports that were later rolled back in 2022 when the pandemic was deemed to be over. And that explains the commensurate rise to oftentimes higher than pre-pandemic levels for food insecurity. So right now, we're looking at north of 700,000 Kentuckians facing a chronic lack of nutrition that is secure, and this is concerning to us. Food insecurity is a vicious cycle. It leads to a decrease in options and quality of your diet, which leads to a decrease in healthy behaviors when it comes to eating, which, as the previous presenters pointed out, does lead to chronic disease, which will ultimately lead to an increase in healthcare expenditures, a decrease in employability, which will ultimately decrease your household income, which feeds into the snowball effect of increased food insecurity. It is a vicious cycle and is one that we, as an organization working collaboratively, try to insert ourselves in between. So the main tagline I would leave you with today is that hunger does not have a zip code. It exists in every Kentucky town, in all 120 counties across the Commonwealth, but food access does have a zip code. And the amount of access that folks across our state have varies widely. Starting with the definition of food deserts, the National Institute of Health defines a food desert as a neighborhood or community that has limited access to affordable, nutritious foods. So there are 3 A's that I would point you to when it comes to understanding a food desert: access, availability, and affordability. And I'll get into those briefly. It's also worth noting that this is not just an urban problem. It acutely affects rural areas as well. So I want to reference this report from the Institute of Medicine and the National Research Council that understood pretty comprehensively in a longitudinal study that I'll give to you after this hearing the public health effects of food deserts. And they found that an estimated 1/3 of America must travel more than 10 miles to find fresh produce. I was in Henderson, Kentucky this last week, and now on my drive to the western part of the state, I was not surprised to see how many rural towns, like Representative Lockett pointed out, Dollar Generals are their only source of food. Preference is not the only factor for consumer choice, nor is it necessarily proximity and transportation availability. Affordability also has a role. This same report found that in the transition to the 21st century, the cost of fruits, veggies, dairy, and meat remained relatively constant, adjusted for inflation. But the cost of products like chips and sodas plummeted, which did lead to a shift in consumer choice towards the more affordable, easily filling options. I have right here the community needs assessment done by the University of Kentucky in 2023, which sought to understand from 8,630 Kentuckians what is needed in our communities, what sort of education, what sort of awareness needs to be brought. And again, I'll be happy to provide this report for you afterwards, but I took out a snippet of this for your reference. Almost 20% of respondents noted that food access, knowing where to find their local food pantry, where to find healthy produce, how to use their benefits properly to benefit a healthy diet, was something that they needed and or wanted education on. And this is something that I think the General Assembly will find really interesting as it moves into session 2026, especially since we heard Roger McCann's presentation on how SNAP education is shifting. This is a great opportunity for the state legislature to step in and fill that gap of education. I don't want to go through and rehearse what CHFS presented about an hour ago, but the one point of this that I want to take out to highlight for y'all is that SNAP provides 9 meals for every one that our food banks do. So for every for every 1 meal that Free Store provides to Northern Kentucky, SNAP provides 9. And the main takeaway from today is at Feeding Kentucky, we just want SNAP benefits to stretch further for Kentuckians. That doesn't necessarily mean increasing the dollar amount that they're getting, but making sure that they have access and then they have affordable food within their reach. So what are some options in terms of increasing food access that we're excited about? So the Lexington mobile market is a great example. It's a great option for expanding food access reach. It's coordinated by our very own God's Pantry, which is centered out of Lexington. It covers, I believe, close to 40 counties in Kentucky. And it brings Kroger neighborhood-style markets to local communities, emphasizing local produce. For folks living in rural or disconnected areas that don't have a Kroger or Walmart within reach, this is a way that they can receive that fresh produce without traveling 10-plus miles to get it. Also, it accepts SNAP, which is a game changer for these communities if they don't have to use their debit cards. Similar to Roger McCann's presentation on the Louisiana pilot, and he noted how they're watching to see how that pans out, we have an indication of how pilots like that do pan out. In 2011, the United States Department of Agriculture hosted a identical pilot in Massachusetts for over 55,000 households all across the state. And they were seeking to test how a cashback nutrition incentive style program would increase or decrease fruits and veggies consumption. So their model was, again, identical to Louisiana's, 30 cents on the dollar cash back for every dollar spent on fresh fruits and veggies, or TFVs, as they referred to it in the study. And the results, the findings, were pretty impressive. It was a statistically significant 26% increase over those not participating in this health incentives pilot. Additionally, they found that across the board, HIP households spent more SNAP benefits on TFVs than non-participants, and they only earned an average incentive of $365 a month, which is not very much back in an EBT card, which goes to show that it doesn't take a whole lot of incentive for folks to start making those different behavior choices. Additionally, retailers reported that there was no real change in checkout time across the board, so it's not going to affect their bottom line or their ability to move customers in and out. Representative Lockett, you wanted more information on the Kentucky Double Dollars program, and I'd be happy to provide some more context. I work really closely with Community Farm Alliance. I work with them on a coalition called the Kentucky Food Action Network, or KFAN. So we work alongside them, and each year we are blown away by the impact of this program. Kentucky already has a nutrition incentive program for SNAP, and especially when we talk about increasing or bettering health outcomes for these vulnerable Kentuckians, I would point to this as the gold standard. They work with over 1,000 farmers annually. They have 80 locations across the state and growing, and they have had $4.56 million in economic impact since 2017 when the program started. It increases on-farm employment, and it increases the fruits and veggie sales amongst consumers substantially, especially as they accept SNAP. And they have, as of right now, 2021's final tallies, they had 12,000 participants statewide in the 49 farmers markets, the 19 Fresh Stop and community markets, 5 retail locations, And what I would encourage is, if we can find a way to make way in the Kentucky budget for an expanded nutrition incentive program, we can see benefits like this scaled up in a way that doesn't just translate to nutrition outcomes, but also to health outcomes. So final recommendations. Roger McCann also briefly mentioned the Thrifty Food Plan, and I wanted to touch on that a little bit more. Previously, SNAP benefits only scaled upwards according to inflation, but in October of 2021, the administration passed a Thrifty Food Plan, which scaled benefits up to put a healthy diet in a more attainable reach. So for most people, that translated from about $4.80 a day to $5.20 a day. But unfortunately, this was recently removed in the recent congressional budget, and we encourage this as an option to put those healthy diets in reach for folks where healthy food does indeed cost more. A little bit extra back in their pockets does translate to more healthy food consumption. Additionally, SNAP education outreach, as I mentioned, fully funding any future cost shift to the states as soon as that takes effect in 2028. And then, of course, any way that we can implement a nutrition incentive for the state would be ultimately beneficial. The last thing is a shameless plug, admittedly. The Feeding Kentucky is going to be implementing the first hunger study in 10 years across the state. We are partnering with the Cabinet for Health and Family Services to analyze everything you could possibly want to know about food insecurity across the state. Why are people going hungry? How many? How much of it is related to socioeconomic status? How much of it is related to food deserts or transportation problems? How is a lack of food access contributing to mental health, to physical health, to employability? Are people paying for food rather than their utilities? Are they having to choose between medicine and putting food on the table for their kids? These are all questions we're asking, and hopefully by session 2026, we'll have some answers for you. The last note I want to leave us on is that hunger is not just a matter of policy, it's also a matter of priority. We have evidence-based pilots and incentives that we know work. It's a matter of putting those items on the table and making them a reality for hungry Kentuckians that will really go the distance, that will make a difference in making Kentucky healthy again. So I want to thank you for your time. I am really honored to be presenting here today, and any extra information I can provide for y'all, I'd be happy to.
Thank you, Jordan, very much. We are very short on time, so I'm going to ask the questions to be brief. Senator Wheeler.
Thank you, Mr. Chair. And is it possible, I guess, to program the cards to where certain things go through and certain things don't, or even limit certain things that go through on the cards? Say, like, if you buy healthy fruits and vegetables, it'll swipe all day. If it's a bag of Lay's potato chips, it might allow one a month, or that type of thing. I mean, again, we live in the 21st century. This seems to me to be the type of stuff that you should be able to utilize to encourage better behaviors.
Thank you for the question, Senator Wheeler. Not to my knowledge, I'd rather not speak than misspeak on this, but what I will say is, especially where SNAP restrictions are concerned, a lot of the times it's the onus of the retailer to administer it, so where if certain barcodes aren't allowed, it's upon the retailer to make sure that those items are not purchased at checkout and aren't purchasable with SNAP benefits. Programs like WIC already don't allow certain purchases, but it's because they were implemented with those restrictions in place. It's a lot easier to administer a program like WIC, Women, Infants, and Children. Whereas with SNAP, if you're adding in extra restrictions, when you have 20,000 new barcodes added each year to retailers to keep track of, that gets really difficult for them to do the work of watchdogging that. If it gets to the point where they could do that through technology, that's an entirely separate discussion.
And that's the point I'm making. I think that would be very difficult to throw on the retailer, except if the card wouldn't swipe, then kind of like a credit card, sometimes it won't allow certain things on it as a limit, that type of thing. I mean, it seems like you might be able to program the card to where, if you're going through the checkout line, well, like beer, for example, I don't think you can swipe an EBT card and get beer. So,
Correct.
Why couldn't you program the barcodes to reflect other things too?
Especially when it relates to alcohol, that is one of those examples that I mentioned where the program was set up to not allow purchases for certain things already. Retroactively prohibiting certain purchases requires extra work. When the program SNAP was set up, it wasn't ever allowed to purchase liquor or beer, which was baked into the program and the barcodes at the start. So the retroactive movement, I think technology would make that process a lot easier, but especially for those mom and pop stores out in Appalachia, that, like you said, it's a lot of administrative burden for them.
Thank you.
Thank you.
Our last question on this comes from Representative Callaway.
Thank you, Chairman. Looking at the incentives idea, my concern is that if we incentivize without educating, it's going to lead to waste. So individuals are going to buy the produce and then not know what to do with the produce. And so I wonder, have any states implemented something similar to, I hate to say brands, but like HelloFresh, to where, ingredients come prepackaged for you with the recipe card, and then it's instructions how to do it, how to cook it. All the ingredients are there, delivered to your door. Has something like that been done in other states?
That's certainly an innovative idea. Not for SNAP that I'm aware of. The closest thing I can think of is Food as Medicine or Food RX, where the boxes that you receive are tailored to your chronic illness, like diabetes or hypertension, for example. But what I will say is our food banks do participate. Separate of SNAP, our food banks don't accept SNAP. That's not how the systems work. But our food banks, a lot of them, when they administer boxes, will include things like recipes, where if you're receiving 50 pounds of produce a week, it includes ideas on how you can use that besides pure cucumbers, here's squash, have at it. It's instead a guide of here's exactly how you can get the most out of what we're giving you. And I don't think that nutrition incentives need to exist in a world separate of education. I think that's an excellent opportunity for them to go hand in hand. I think SNAP education is crucial, especially if we're going to be doing a nutrition incentives pilot. It makes absolute sense that if they're going to be buying more fruits and veggies, including information on how best to utilize those produce items makes complete sense to me. But not to my knowledge that's not been implemented anywhere else.
Thank you, Jordan. One of the things I know that we will talk about probably in another meeting that we've discussed before in terms of fruits and vegetables, you don't have to look any further than a school meal when, if it's mandated that every kid get an apple, and then at the end of the school you go and look at the trash can, what's in the trash? Apples. So there's a lot of education there. There's a lot of things that we have to talk about. Thank you, Jordan.
Absolutely.
For your
Thank
testimony.
you so much.
We certainly appreciate it. Our next presenters, we have asked them to actually come up, and I'm going to ask Steve and Fielding and Sarah if they would to come up, and then Jimmy, we'll kind of hold off on you until after them. But we have asked them to come up and give a short overview and testimony in the event or if the legislature decides to apply for a waiver for sodas, chips, energy drinks, snacks, those types of things from the federal government, what kind of impact that would make on their business, and just to give an overview of what they do, what they are doing in the industry as well. So, gentlemen, and Sarah, I will ask you if you would please introduce yourself and your title, where you work, and then proceed with your testimony.
On behalf of the Kentucky Beverage Association, we appreciate this opportunity to come and present to you. Steve, I guess you want to start.
Yes, I'm Steve Richardson. I'm the president of the Kentucky Beverage Association. I am also the senior market director for G&J Pepsi, which is a family-owned beverage organization based out of Lexington. We've got just shy of 500 employees employed in Kentucky with locations in Maysville, Campton, Winchester, obviously Lexington, and Harrodsburg.
I'm Dallas Clark. I'm president, CEO, and chairman of Clark Coca-Cola. We have 3 operations servicing Kentucky, Campbellsville, Bowling Green, and Tell City, Indiana. We have 275 employees. We cover about 23 counties, and this year we will celebrate 145 years in beverage business. We started in Kentucky in 1880.
Very good.
I'm Fielding Rogers. I'm the 4th generation owner and operator of 801 Bottling. My great-great-uncle Lee founded the company in Winchester in 1902, where we remain 123 years later. I personally hand mix the secret family recipe for every bottle of A-Lite made. We're a Kentucky proud brand, and we strive to be a brand that all Kentuckians can be proud of. In fact, we helped the state launch the Kentucky Proud program. We regularly donate and send A-Lite to Kentuckians on active duty military service. We pay our 120 employees a living wage and offer excellent health insurance, a 401k match, and a profit sharing program. And it's part of our philosophy to run the business in a responsible way for all involved. Next year is our 100th anniversary of the A-Lite brand, and we hope to be able to celebrate the achievement with all of you. In fact, I'd like to invite everyone in the committee to take a tour of our facility in Winchester and see how we operate day to day.
Very good.
Hi, I'm Sarah Massey. I'm the Executive Director of the Kentucky Beverage Association, which has been representing the non-alcoholic beverage industry in Kentucky since 1917.
And before your testimony, I just want everyone to know that we actually got Coke and Pepsi sitting at the same table. So we achieved the unachievable.
Look at you.
Please proceed.
Have you taken any pictures?
Yes, we're going to. Go ahead.
Again, thank you for allowing us this opportunity to present. We were asked to discuss the Kentucky beverage industry in relation to SNAP. We want you to have the facts about the beverage industry in Kentucky. I will be sharing 3 things with you this afternoon: the overall impact of the beverage industry has in Kentucky and in each of your communities, how the beverage industry has been successful in responding to consumer desires for more healthy choices in their groceries, and finally, data around SNAP spending in beverages. The Kentucky beverage industry is locally grown, and our member companies are proud to call Kentucky home. From shelves stocked with a variety of beverage choices to stable jobs to giving back, we aren't just a name on a building. We're your neighbors, we care, and we provide products and listen to consumer demand because we are a part of the community, just as we have been for more than 100 years. Throughout Kentucky, our 10 members have 72 facilities where they employ more than 4,000 Kentuckians and support another 71,000 indirect jobs. Kentucky Beverages industry provides more than $552 million in wages and benefits to hardworking Kentuckians. Our members contribute more than $310 million in state taxes, $521 million in federal taxes, and will contribute nearly $40 million through charitable donations. And when our communities are in need, our members are there. When Kentucky has faced devastating weather events, every single one of our member companies were able to deliver cases upon cases of water alongside many other contributions to victims and impacted communities. Sometimes this support even comes from beyond our borders. My own company had team members from our Mississippi facilities come in to help remove debris from the homes after the 2021 tornadoes in Bowling Green. Coca-Cola Consolidated annually packs 600 backpacks that are filled with non-perishable foods for local nonprofits. We brought recycling to more than 28,000 homes in Louisville, helped Powell County kick off their first ever recycling program, and L81 brought glass recycling to Miguel's Pizza in Slade. In 2021, Pepsi Beverages North America helped bring Atkinson Elementary, a JCPS school, physical education, a school that had not had PE class since 2005. We have advocated for oral health in Eastern Kentucky, and the list goes on. Our members, your neighbors, are actively building up Kentucky. Beverage companies have answered and will continue to answer the call to support a healthy, balanced lifestyle with low and no-calorie products. In the last 2 decades, we listened to consumers, policymakers, and the public health community. We have worked together to transform the beverage aisles, deliver clear information, and help Americans find balance. Nearly 60% of beverages Americans buy today are zero sugar. Beverage calories per serving have decreased 42%, with beverages now only making up just 6% of the American diet. Obesity has risen 37% since 2000, while calories consumed from soda continue to go down. Sodas are not driving obesity. Additionally, beverages are the only food industry sector with successful zero-calorie alternatives to their flagship products. Additionally, beverages aren't being bought in bulk. As our product directly relates to SNAP, we like to eliminate one myth, the idea that SNAP participants are only filling up their grocery carts with soda. The USDA, who oversees the SNAP program, tracks this closely. Their data shows a simple fact: households on SNAP only spend 5 cents per dollar on beverages. Designating grocery items as good and bad creates a burdensome food code while taking away the dignity of choice from nearly 600,000 Kentuckians, including 16,000 veterans and 19,000 seniors. In closing, as Kentucky's local beverage companies, we want to encourage you in your work. Americans do want to get healthier, and talking about it, how to help, is a worthy exercise. But the best way is not by restriction, but rather for companies like ours to provide shoppers with more choice in their groceries, along with clear, transparent information. And we know that's the best way to support balance and improve health because it's what our consumers expect from us, and it's what we have been delivering and will continue to deliver. With that, again, thank you, and we'll open up for any questions you all might have.
Are there others that would like to testify? Any of you? No? Okay. Are there any questions from the task force members? A very quiet group we have up here. So one of the things that I wanted to ask, one of our previous presenters made the statement that sodas are the number one purchase made with SNAP benefits. According to your slide, would you say that is not true, or is that true?
I would say that does not.
Could you use the mic?
Yeah, I'm sorry. I would say we're pulling that data directly from the USDA in their most recent reports, which aggregates where SNAP benefits are being spent. I cannot speak to the data that they offer, but that is something that could be clarified by the USDA.
Okay. Any other questions? Senator Douglas?
I just wanted a little bit of clarification. 60% of the soft drinks are sugar-free. Is that? Do we know what percentage? When we look in the supplemental nutrition program, do we know if that's also true with the persons in that program? Is it 60% of what they purchase also sugar-free, or have we ever taken a look at when they purchase foods in this category, or at least beverages in this category? Are they also sugar-free?
So the USDA does not break down the data that way.
Okay.
What we do know is that 5 cents of every dollar, the data that we presented, that is all sweetened beverages, but that does not differentiate between the 0-calorie, the aspartame sweetened beverages, and the sugar sweetened beverages. So we do not have the breakdown of what those purchases are between the 0-calorie and the full-calorie soft drinks that are purchased under that 5 cents.
Okay, thank you. Thank you, Mr. Chair.
Thank you. One of the questions that I have as well is, do you have a breakdown in terms of either the percentage or the dollar amount of your total business that is SNAP benefits?
We would not have that breakdown because the industry, and I'll let them add to this, the industry sells to the retailer. So we are not actually selling directly to SNAP participants. So we would not have that data on who is purchasing at the point of sale.
Okay. Thank you. Senator.
Thank you. And I do love seeing Coke and Pepsi and Ale-8 all at the same table. So what does your information provide us? As you mentioned, 37.4% up in adult obesity. And how is obesity impacted by aspartame and the other beverage sweeteners that are utilized in zero sugar beverages?
Well, I think the data is showing that while sugar consumption, full calorie consumption of beverages is on the decline, obesity is still rising. So that the root cause is not sodas. What I would say is the safety and efficacy of aspartame has long been studied. It's one of the most studied ingredients by all the different food safety agencies around the world. At a later date, I think that is a conversation that I know that there has been a topic of discussion to have this ingredient-specific dialogue at a later meeting, and we'd be happy to be at the table for that. But today, we know that that is a safe product that is not driving obesity.
That's an astounding claim. I've not heard that. And I would definitely like the science behind that claim, please.
Absolutely.
Okay.
All right, thank you so much. We appreciate your testimony. At this time, I will call Jimmy Stewart, Chairman of the Kentucky Grocers and Convenience Association, up to the table for testimony. And please keep in mind that we are now really short on time, so please keep your testimony short. Please state your name, who you work for, your position, and you may proceed.
I'm Jimmy Stewart. I'm the chair of the Kentucky Grocers and Convenience Store Association.
I'm Shannon Stiglitz, and I am the Senior Vice President of Government Affairs for the Kentucky Retail Federation, today representing our affiliate, the Kentucky Grocers and Convenience Stores Association. And we're having technical difficulties that it's probably mine. But I am going to do, so we speak respectful of your time, maybe a supermarket sweep of, if anybody remembers that show. You probably don't. But of our information, since I know that we are short on time. And so many of you had questions that I thought it might be easier to answer quickly, because some of the information is not in our slide. Specifically, Senator Douglas, I wanted to let you know that based on national data that I just pulled from the USDA yesterday, 79% of SNAP purchases occur in a grocery supermarket environment, so to speak. So I hope that helps answer that question. And Senator Wheeler, to your question about loading up the carts, alcohol, tobacco, hot foods are prohibited unless we're in a disaster. Those things are all administered ubiquitously nationally. And therein lies the problem from a retailer standpoint, in that imagine if you are a multi-state operator. Currently now, Indiana has a SNAP restrictions waiver. West Virginia's is being retooled. But to that end, you have to know and keep track of daily, hourly, what all of those states are defining as whether it's you can't sell ultra-processed foods, whether you can't sell soda, whether you can't sell sugary beverages. Because it's not a ubiquitous national system that would be set up. In this instance, it would be a state-by-state type waiver system is what some other states, and I'll give an example, and Chairman Lockett, I'm not picking on your legislation, but in your legislation previously that was filed last session, it said, or other foods as determined to have no nutritional value. And the cabinet would be making those determinations. And so not only in that instance would, in a lot of the waivers, that what we're seeing is they're defining these foods in different ways. There are multiple systems that define what foods are, what a candy is, what a gum is, what a soda is, what a sweetened beverage is. And they're not ubiquitous. It's not easy to do. In speaking with my colleagues across the country who are facing these challenges and who are going through these and have worked with their state legislatures or state executive branches to implement these things, there are things you have to consider in implementing it. I apologize. I'm going to go quickly here, if I can advance. So just giving you a quick impact of what the food retail industry looks like in Kentucky. Independent grocery stores are there. You can read, but clearly the overall impact is about $11 billion in economic impact on the Commonwealth of Kentucky. That is over 27,000 jobs in the supermarket space. Direct jobs in the independent grocer space is close to over 12,000. So just wanted to talk a little bit about SNAP economics. I'm going to skip over a lot of this. I recognize that you can read, but SNAP, according to research, it increases rural industrial output by economic output by 1.25%, and it supports a significant number of jobs in the grocery industry. In Kentucky, for every one SNAP dollar that is spent, it generates an additional $1.79 in economic activity. Nationwide, that ratio is $1 to $1.50. So I think it's also important to understand that 79% of SNAP beneficiaries are children, those in a household with a disability themselves, or the elderly. And I also wanted to highlight that I think someone said this earlier, 22,000 active duty military were reported to be on SNAP in 2022. This is nationally. This is according to a 2019 GAO report. And I also wanted to highlight that SNAP is temporary. You can see how frequently folks go on and off. But here is a critical thing I think it's important to understand, that the information and research that our industry has from our national groups, and I've got to move this box, is that SNAP beneficiaries are $1,400 less in annual medical cost spending than peers in their economic peer group. So economically, based on where they are, having SNAP assisted them in lowering their overall medical costs by $1,400 annually. Just an example of working, how many SNAP recipients are working. I know that we talk about this frequently. Work requirements are changing federally. I'm happy to share that information with you, but wanted to give you a sense of who the SNAP beneficiaries are. And I want to explain something and be very clear. The 2016 report that the Beverage Association referred to, it very clearly states a SNAP customer shops very much like you and I. There is no discernible difference in the products they place in a cart between if you're on SNAP or if you're not on SNAP. 50% of all SNAP transactions involve another form of payment. So, and in Kentucky, we were the first state ever to place SNAP benefits on an electric card. But along with that, and I put a copy of the card on there, a little scary how easy that was to copy off the internet. It doesn't look very good. I don't know who D. Barrett is, sorry. But let's look at a SNAP transaction. I go in, I have my cart. I started in the produce section. My dairy is on top. I got my bread and my eggs over here in my little basket. First item that goes on the belt that is eligible for SNAP comes off of your SNAP benefits. If you are also receiving government cash assistance, that cash assistance in Kentucky is also on this card. And so what will happen is if you were purchasing, let's say you purchase a rotisserie chicken, toilet paper. Those are two items that are not eligible for SNAP. Those items will be taken off of your government cash assistance, or you will be asked to provide another form of payment. So again, this is I'm going to let you read this, but this is a little bit just in more evidence of how a SNAP consumer's basket looks. The first week when the benefits hit their cards, they're buying protein, eggs, ground beef, bananas. Bananas are apparently the most common thing purchased on SNAP. And so then you get into that last week and they're stretching that SNAP dollar. They're buying shelf-stable items, foods that they can stretch, cereals, breads, pastas. And I wanted to talk about this SNAP data. I will be really anxious and excited to see the information about soda being the number one purchase on SNAP, because I have the USDA reports right here, my trusty little 2014, 2016. It doesn't matter. They're both analyzing the exact same data from 2011. And what you have to understand that when they're looking at this data is it does not include purchases from farmers markets. It excludes those. I would assume that would be a high percentage of fruits, vegetables, fresh meats, eggs. Those vendors are not included in the 2011 data and therefore cannot be analyzed. Additionally, what this 2016 study is looking at, and there's a link to it in the presentation, is that it is evaluating not what is purchased with SNAP benefits. It is studying what a SNAP beneficiary purchases. Now, why is this critical? Because it's critical because we're talking about a SNAP program restriction that would likely be for grocers. The concerns are we support all the programs and healthy incentives that were referenced here today by my counterparts. And so what you would think, I do have them. I haven't used a mouse since like 1998. I don't think an actual
So
mouse.
Shannon, due to time, I'm going to go ahead
Okay.
and stop you there. We do have a couple of questions,
Sure.
Senator Wheeler.
And Shannon, I think going on my comments earlier that you addressed a little bit, and the last thing I want to do is make things more difficult for mom and pop grocery stores. But as I was talking with my colleague Representative Callaway, obviously every time a new product comes out, it gets a barcode and a number. Why couldn't the state, like the cabinet that manages just put that number in a prohibited category so that when it goes through, it's just not going to, I guess based on what you've told me here today, which is good information, I didn't realize cash benefits and SNAP benefits were on the same card, that the prohibited items, I guess, would then be pushed over onto the cash benefit because, again, I think, and as far as farmers markets are concerned, I mean, I like the farmers market. I go to my one in Pikeville. I don't see SNAP beneficiaries at the farmers market, okay? I can barely afford the farmers market a lot of times. I mean, it's generally soccer moms and doctors and lawyers, and I mean, it's expensive stuff, okay? It's a lot cheaper to go to Food City and get tomatoes, but I like to support my local people that grow stuff or get some half runners. You can occasionally find them there. So for some reason grocery stores don't seem to have those as much anymore, but it's not as cheap as going to the grocery store. So I guess, but going back to my basic question, why couldn't you just put these numbers in a prohibited category? So for example, candy bar, Hershey's bar goes with that barcode in the prohibited category. A Red Bull goes in that prohibited category. If it's bananas is on the barcode's on the good list there. I mean, I just don't see in our highly computerized society why that's not possible. And then when the card swipes, it's really kind of doing the work for the retailer, is it not?
Well, I mean, I'm not saying that's not technologically possible, and that's what these states who have submitted these waivers are doing. But what I'm trying to say is someone has to pay for that technology, and in the states where these waivers have been approved, they are paying for the systems to set this up. So there is an inherent cost in tracking that information that would be borne by the state. Gotcha. Additionally, there are 600,000 SKUs in the marketplace today. Your average supermarket has about 32,000 of those on the shelf, and 22,000 come on the marketplace. If it is a moving target, and again, Chairman Lockett and Chairman Funky From, I'm not picking on your legislation, that would have been a moving target because we had been constantly worried about what the Cabinet for Health and Family Services was saying. But additionally, you have to think about the fact that a SNAP benefit is portable across state lines. So West Virginia doesn't have it now. Virginia is not, I think, is not considering a pilot currently. If a SNAP consumer can simply cross state lines and purchase those prohibited items, then potentially the customers in your marketplace lose that customer.
Okay, maybe that's where I'm misunderstanding it because, okay, it's portable across state lines, but
Yes.
if the Kentucky Cabinet for Health and Family Services has, I mean, I guess if it's a state-administered program and it's on our prohibited list, even if they take that card across state lines, are you telling me that the Kentucky system won't block that?
That I don't know.
That's
that
the
is
point
one
I'm
of the
making.
questions that we have asked is how would that impact this state's error rate? But to your, I think your ultimate point is, and to our ultimate point is, there are potential unintended consequences and bureaucratic administrative nightmares that for retailers that they could be facing, particularly with 50 different policies and 50 different waivers for multi-state operators. But bottom line is we understand your goal is to reduce healthcare costs and to get populations that need it most healthier. But we question whether this specific policy will actually go to that goal, because I don't think the consumer will feel that, hey, I can't purchase that Snicker bar, I'm going to go get the banana, because of the way the interoperability of the benefits together.
I get you, but you're saying if it's a government cost, then I guess then we as a government are choosing to take that on. It's not being borne by the consumer. So we're not asking the people receiving these benefits to pay anymore. I think what I'm saying is if we make that change, we as a General Assembly, governor, or whomever, that's input on this bill, that's a cost we're willing to make, like building a flood wall to make sure houses don't flood, to building, lots of different things that government agrees to take on. I mean, so if we agree to pay for that system that would monitor these things, then, will we not be taking that burden off of the convenience store? Because that's not, I don't want to put it all on you, but if we take the burden off of you, then where's the problem?
Well, our only experience, in all honesty, with the restrictive food programs is with WIC. And if you look at the WIC program, about half the number of retailers participate in WIC that participate in SNAP. A lot of that has to do with the cumbersome and bureaucratic nature of how WIC has to be administered. They select one baby formula, correct? Yeah. One baby formula that you can only purchase. I'm not talking about one baby formula that's formulated this way. I'm talking about one specific brand. And so I don't want to diminish the potential impact on retailers. Even if the state bears the cost, the technology cost, the retailer is going to be interacting with that system, ensuring that their shelves are marked correctly, ensuring that their customers know what is SNAP eligible and what is not. And that is going to be bureaucratically difficult, particularly with 50 different, or let's say 25, I think we're estimating that 25 states are looking at this, 25 different policies for operators who are operating. And to your point, if you're a mom and pop in West Virginia or Kentucky, and you have to know and communicate with all of the different Kentucky systems, because this is my understanding, and I will get more information about this, but Idaho is seriously looking at how they're going to make operable their current processing system with a system that considers the restrictions. And so doing that, they're delaying and being thoughtful about how they're implementing it because they want to get that right and are concerned.
I think one of the things that we want to make clear as a testimony, and we're going to end here as a committee, is that as a Commonwealth and as a state, we are very invested in the health of Kentuckians, because we know that a lot of recipients of SNAP benefits also are on Medicaid. And so the down the road causes, the down the road costs of those recipients being unhealthy is also borne by the state. And so it's in all of our best interest to get to the root cause to do what we can to get all of us healthier. But I want to point out to our committee members as well, there is a written testimony in your packets from Tom Underwood from the Kentucky Wholesale Distributors Association, so please make sure and read that. Thank you for your testimony. We certainly appreciate it. It's been a great day, great testimonies. Our next meeting will be August the 20th on Wednesday at 3 o'clock. Hope all of you are very safe. Have a wonderful evening. We're adjourned.
Well done.
All right.